Good morning, everyone. My name is Mustafa, Group D1. Today's presentation will be about salivary gland diseases. Starting off with the classification of salivary gland diseases, which are divided into 6 different categories. Starting with category number 1, which is developmental, we have aplasia, which is the absence of the gland, as we can see here. We don't have a Stevenson duct or the gland itself. We have atresia, which is the absence of the duct. We can see here we don't have the submandibular duct, and we have aberrancy, which is ectopic gland, as we can see in this OPG. We have enlargement of the gland. We have non-inflammatory, such as Sjogren syndrome, or inflammatory, such as viral, bacterial, allergic. We have the mumps. Category number 3, which is cysts. We have extravasation cyst and retention cyst. And we have a ranula as well. Category number 4, which is a gland neoplasm, we can be divided simply into benign and malignant. We have an example of a benign, which is polymorphic adenoma, hence the name adenoma. And the malignancy, we have adenocystic carcinoma, the name carcinoma indicates, hence its malignance. We have other cells that follow into these categories, such as basal cell adenoma, and malignancies, we have basal cell adenocarcinoma. We have the necrotizing cyalometaplasia, which is the necrosis of the minor salivary glands, normally found in the hard palate. We have salivary gland dysfunction, which is the final classification. We have excessive salivation, cyalorrhea, and dry mouth, such as xerostomia. In this case, we have excessive salivation, drooly saliva. We are using ultrasonic guided Botox injection. In this case, for the parotid glands, they will be injecting about 0.5 cc of Botox using ultrasonic guided technology. Now, starting with the first one of the known diseases, sialolithiasis, also known as salivary stone. In this disease, we have the formation of salivary stone, which will result in the obstruction of the salivary flow. What is a salivary stone? It's a hard substance formed in the parenchyma of the duct, of either major or minor. It is a crystallization of saliva, salivary solution. It is yellowish and white in color, single or multiple, ranging in size from 2 centimeters or more. It is said that the salivary gland will grow in a rate of 1 millimeter each year. So, what other complications we can have? We can have inflammation of the gland, and when there are a lot of salivary stones in the gland, we have to remove the duct. 90% of the salivary stones will be found in the submandibular gland. Why is that? Because the submandibular gland is long, curved, and we have a curved Wharton duct, increasing the chance of entrapment of organic debris, and the secretion in this particular gland, is higher in calcium content, thicker in consistency, and the position of the gland increases the chances of stagnation. It can happen as well in other glands, such as parotid gland, but is 90% in the submandibular. And we can see systematic representation of the salivary stone. Clinical features, it's most commonly seen in middle-aged people. when there is when major gland is involved, there will usually be pain present. Why the patient complains of pain? Pain and swallowing happens after and during and after eating, due to obstruction of the gland and preventing the salivary flow and increasing the pressure, thus producing pain. On examination, the stone can easily palpated, if, especially if it's in the peripheral aspect of the duct. So, what are the investigation we could do to locate the stones, the salivary gland stones? We have the AP, anterior posterior view, X-ray, the lateral, and the occlusal view, as we can see here, clearly demonstrates the stone. We have other methods such as sciallogram, and we could easily demonstrate the presence of the salivary gland by injecting a contrast medium, which can be seen by the X-ray. The contrast medium is usually opaque. Now the management. For smaller stones, we can easily milk the gland to remove it by opening the duct and manipulating it by hand. Whereas the large stones, should be removed surgically. Sometimes when the stones are not completely impacted, we can extract it through intubation of the duct with fine, soft plastic catheter and application of suction tube, thus creating a suction and pulling the stone from the gland into the suction tube. If we have a case of multiple stone, we have to remove the gland as well, and we have modern technologies such as piezosurgery. Now, I'll be demonstrating a surgical removal of the gland. This surgical removal is indicated because of the presence of multiple salivary stone. Here we can see in the patients there is enlargement and swelling near the angle of the mandible. The surgeon marks the angle of the mouth, so the incision will not lie near the mandibular branch of the facial nerve and avoids all the major structures in the angle of the mouth, as well as marking the skin crease. So he can manage an incision around the skin crease so the scar will be less visible. This is the reason why the surgeon marks it, so he avoids the major structures and make an incision along the skin crease so it's less visible. After making an incision, the surgeon will try to milk the gland and remove the salivary stones. But the surgeon found during the surgery that there will be the gland is completely entrapped with the stones. Therefore, milking the gland or trying to remove the stone was not an option. Therefore, the surgeon opted to remove the gland. In the surgery, we can see that this is the gland, this is the glandular structure. Now he's dissecting the gland from the original structures underlying the muscles, keeping inside the presence of major structures and nerves. This is the stones, as we can see. Now it's removed by the suction. Now the gland is removed, and the surgeon is inspecting glands for any abnormalities and removing the stones as well. So he might find a neoplasm or anything. And after the surgery, complete removal of the gland. This is the stones, salivary stones. The surgeon sutures with interrupted suture the incision lines, so it's tightly matched and with minimum scar formation. Moving to another procedure, which is done, and both procedures are done in GA. This is another example. This is a gland, smaller gland, marking the incision, making the incision and dissecting with a surgical scissor. Then the surgeon will switch into artery forceps for exploration of the surgical sites and detachment of the gland from the gland, and using suture for retention, for reflection and retention of the tissue. Now we're moving into the salivary gland enlargement, which is MIMPS. We have the first one, MIMPS, which is epidemic prioritise, which is done due to a viral infection of the salivary gland by the paramoxy It's acute and contagious disease, and occasionally affects the submandibular gland, other and the submandibular and sublingual gland, but usually the parotid glands are affected. Hence the name epidemic parotitis, because it affects the majority of the disease affects the parotid glands. Moving from that, this disease is self-limiting, and the incubation period is from 2 to 3 weeks. The child and it usually mostly affects the children. Now, the incidence of mumps has decreased due to the presence of vaccine. The patients usually experience symptoms like fever, headache and chills, and vomiting, and the gland will become slightly rubbery or elastic, and frequently elevate to both sides, and elevates bilaterally and the earlobes as well. Cellular also known as inflammation of the gland due to viral bacterial. We have bacterial infection, as in acute bacterial celluloadenitis, caused by commensal species such as Staphylo aureus, Staphylopyogene, Staphyloviridans. Especially, it affects the neonatal, the children, or debilitated adults with poor oral hygiene. Some drugs can produce similar effects, such as antidepressants, antihistamine, tranquilizers, and anti-Parkinson drugs. In the investigations, we will find a high leukocyte count. Cyelogram should not be performed in the presence of suppuration, because we are injecting a contrast medium, and therefore we're spreading the infection further into the gland. Culture should be collected. Pus should be collected from the gland, taking care not to contaminate the swab with the microflora. The management is usually with antibiotic, palliative therapy, hydration of the patient, and improvement of the oral hygiene. In cases we need to do surgical drainage, we could do it using needle aspiration, guided using the CT scan or the ultrasonic. In this video, I'm showing you the ultrasonic guided injection. This is the ultrasonic device, and the surgeon or the technician is looking for the site of injection. Once done, the surgeon will insert topical anesthetic into the location and do a fine needle aspiration using a needle. In this case, seeing the needle, inserted the needle into the site and removed it. Now, the chronic bacterial sialoadenitis, which is also caused uh, especially in children, it may be idiopathic with factors like duct obstruction, congenital stenosis, and Sjogren syndrome. All these factors, except by these obstruction by the stone, is seen commonly in the parotid glands. Clinical features, it's usually unilateral swelling of the angle of the mandible. The gland may undergo atrophy, and this decreases the salivary gland flow. Management by antibiotics, intraductal infusion with antibiotics, and as well as occluding ductal system with protein solutions. And in such cases, in severe cases, the removal of the gland should be indicated. Moving into the mucil, which is we have in the mucil, which is cyst, by the way, cyst of the salivary gland. We have the first one is the mucil. We have two different distinct entities: true retention cyst lined by epithelium and a mucosal extravasation without epithelium. The site are seen the majority in the lower lip. Clinical features: we have small superficial painless well circumambulated swellings. Treatment inoculation will result in reoccurrence of the mucocele. Therefore, it's advisable to do a surgical removal. In this case, we'll be exploring the diode laser removal. In this case, we will not get a biopsy sample because the laser will ablate the tissue. In this case, we're seeing the complete ablation of the mucocele. This is the mucocele. This is cyst. Now it's completely removed and cauterizing the wound with a laser. This is 3 weeks post-operative. We have ranula, which is the presence of, it's a variant of mucocele, present in the floor, mostly in the floor of the mouth, beneath the tongue, owing to its resemblance of a frog belly. It's been termed ranula. There is superficial ranula and the plugging ranula. The etiology, it has been reported that the ranula occurs because of the extravasation of a mucosa due to trauma or excretory ducts of sublingual gland. Now, the clinical features is a dome-shaped bluish swallowing of a superficial ranula, may be located laterally on the floor of the mouth, beneath the tongue. The tongue may be raised or displaced as it enlarges. This swelling may cross the midline. The treatment, marsupialization, will result in reoccurrence. Therefore, it's advised to do surgical removal of the sublingual gland. In this case, we can see the patient with a massive ranula beneath the tongue. During the surgery, the ranula is removed using surgical manipulation, reflecting the underneath mucosa, taking caution not to traumatize the vital structures, especially in the floor of the mouth. And now this is the ranula, which is removed, and the surgeon continues with suturing after removal. Now we have benign tumors, polymorphic adenoma, which consists of more than 50% of all tumors and 90% of all benign tumors of the salivary glands. It affects both major and minor salivary glands. commonly affects the parotid gland. This tumor created a lengthy argument regarding its histogenesis and management. However, most workers believe that the tumor arises from the myoepithelial cell of the salivary gland. The different tissue types of both epithelial and connective tissue elements are seen in the tumor, thus giving the name mixed tumors. So we can see here, it's the largest near the angle of the mouth. We can see as well in the floor of the hard palate. Clinical features. It mostly affects the parotid gland, followed by minor salivary gland of the palate, and less frequently affects the submandibular gland. Majority of the lesions are seen between 4th and 6th decay, more commonly in the females. The tumor starts in small painless nodules, either by the angle of the mandible or beneath the earlobe. The nodes slowly increase in size, which may be characteristics show intermittent growth. The gland is well circumambulated, encapsulated, firm in consistency. As we can see in this picture, we have the tumor as well as the parotid gland, and this is called recurrent polymorphic adenoma. Biopsy incision, either by core biopsy or fine needle aspiration, or excisional biopsy, as in this case, the surgeon makes the incision, removes the tumor, and then sutures the remaining tissue. As well, we have core biopsy or fine needle biopsy. In this case, we have the histogenesis of the biopsies. We can see the classical features of polymorphic adenoma of the tubules and the glands found in the biopsies. And the white circles are fat. Polymorphic adenoma can be treated by surgical excision. This is before and after the surgical incision. It's done under the GA anesthetics. The surgeon reflects the mucosa. Now the tumor is removed. Surgical inoculation of the sites and palpation of the sites. And afterwards, suturing of the remaining mucosa. This is the extraoral approach. This is the remaining cyst, which is removed, and the preserved biopsies, which are from the surgery, will be sent into the labs for further investigations. That was my part. Thank you for listening. Goodbye.